be speaking on cement spacers for hip. Uh, the cement spacer, as we know, is the workhorse in a two-stage hip revision. When we do a two-stage hip revision, which is the gold standard for any infection, if it is not very early infection, the first stage implant is removed, thorough debridement and spacer application. Second stage, the definite fixation is done. So the cement spacer, when you think of a cement spacer, we should know what are the advantages of it. It improves function, decrease the time of the second stage, decreased arthrophybosis and maintain space and local spread of antibiotics, which is helpful for decreasing the infection. The disadvantages, of course, are there. The spacer fracture may occur. There may be debris which may be a source of infection later. Bone fracture and lysis due to local stress, dislocation and bacterial resistance can occur if the antibiotics are not correct. The types of cement spacer, two types mostly: the articular spacer, the dynamic spacers, the non-articular, the static spacers. The articular spacers can be preformed or it can be made on the table using different methods. But non-articular spacers are usually made on table, and the non-articular spacers are used mostly in major bone loss and soft tissue loss and need limited or no motion for wound healing. So for wound healing, it's better to go for the non-articulating spacer whenever there is loss of major bone loss or soft tissue loss. The larger surface area for good illusion is important, and non-articulate spacer helps in that. Non-articulate spacer, soft tissue contractures and diffuse osteopenia is a drawback of these spacers. So the points to decide for the articulating spacer, we should know that the articulating spacer, there is decreased length of stay in the hospital, improved range of movement is there, dislocation rate is lower than that when we are using articulating spacer. There may be periprosthetic fracture, but it is almost lower than that of a non-articulating one. Infection eradication is almost similar to that of a non-articulating spacer. The different articulating spacers, as discussed, they can be prefabricated, which is ready-made, limited size available, and they have low antibiotic cover, and they have less amount of delivery at the site. The on-table with hip molds, different hip molds are available for quicker, but they are costlier. And on table we can make with local gadgets, which is quicker and cheaper, and with hand it is associated with more complications. The antibiotic elution in these cases, the time it peaks within hours, it almost finishes by 4 weeks. So beyond 4 weeks, it acts as a spacer only. The type of cement and the type of antibiotic all decide the elution criteria. Spacer preparation technique, if you have a superficial antibiotic coat nowadays, it is approved for better antibiotic delivery at the site. So different antibiotics can be used in a 40-gram cement. We can see that better to use powder form of the antibiotics to better mixing with the powder of the cement rather than the liquid. The vancomycin is mostly commonly used. It can be used up to 0.5 to 4, and different antifungals like amphotericin and voriconazole can be used whenever the fungal infection is suspected. For gram negative, as we have tobramycin, gentamicin and ceftazidime, which are commonly used in these cases. Sometimes exchange spacer or repeat implantation of the spacer can be done by persistent infection, wound-related problems, draining sinuses, mechanical issues when like fractures, if it is there, then we have to go for a repeat spacer. So the time period to keep the spacer is very controversial, but a short stay up to 6 weeks is recommended for reimplantation with systemic antibiotic cover up to 3 months, as discussed by Dr. Javed. Chances of resistance reinfection increases following stay beyond 6 weeks. A long stay up to 3 months for delayed wound healing and sign of persistent infection are there, which should be taken into account. So this is how you make a cement spacer. This is this I follow, and this has been done by Dr. Javed only, and he is the master of this. So So you can see that you can use a Steinman pin and bend it to the amount of angle which you want to prefer, almost 135 degree, and make the stem keep the accepto ball that usually it is used and they are available in the OT. The accepto ball acts as a head and we can manipulate it to form according to the shape of the head which we are using. Then the stem can be put on that and we can see the amount of length which we want to keep and cut it at that point so that it is not too long for that. And then we cut the accepto up to the middle so that it is easy for us to overlap and make the size according to the head which we want to use. So we overlap the cut accepto head and then the amount of overlapping at which the head is obtained, the size of the head is obtained is cut, and we can see that the head size is almost equal to the desired head. And then we go out and suture with any suture which is available. ATO suture also is good enough, and that seals the whole of the head, and we'll open the distal part to make the opening for the passage of the cement. So this is how the whole head is prepared, and it is almost equal to that of the desired head size. So this is how it is totally sealed, and the cement will be pushed into the in the Davi state, it will be pushed inside it, and before that you have to add the antibiotics and press it inside so that the whole thing is filled and the Steinman pin is in situ in that. So just 50 minutes. So then we have to go ahead and do the stem part. The stem part has to be of the size of the desired rasp which we have used for preparation, and the extra cement has to be taken out distally by making it thinned out towards the distal part. So before the cement is set, so you have to be sure that it has to be of the size of the spacer which we are using.